2 weeks of a module that you took part in 1 to 2 classes of mental health. And then for the 5th, you just had 1 day observing at an inpatient psych here in the class. And they shared how for their ADN, associate's degree in nursing, how long was the associate's degree?
2 years.
2 years, okay. In the 2 years of their nursing, they received 1 for sure, maybe 2 classes of mental health, and then 1 day of observing in a mental health facility. And that was their whole schooling for mental health. Hey, good to see you.
Yes, good to see all of you.
Yes.
Thank you for inviting me.
Welcome. So yeah, so I just wanted to bring attention to that, because that really speaks to the support that the nursing needs, because the amount of mental health issues that we see in the hospitals and in the clinics and communities or wherever we're in public health is epic proportion in my mind.
Oh, absolutely. And one of the first things I want to say is thank you for doing this, Heather, because as a medical social worker and a mental health provider in hospitals and clinics and working in hospices and palliative care, I will tell you that one of my greatest sources of frustration is the lack of understanding of mental health and the lack of attention in training to mental health. And I want to start with asking the two of you to give me any questions you have. I'm going to open my chat. So if you have any questions for me, you either can speak them out loud or chat me, because I want to make sure I answer your questions. But the first thing I want to say is the biggest misunderstanding around mental health and mental illness is that mental health is something we all have and we all deserve. And it's quality of life, which includes your physical health, your emotional health, your spiritual health, and your psychological health. And when those things are in balance, that's wellness. And that's what we all strive for. That's very different than mental illness. Mental illness is a category given to diseases, diagnoses that are physically oriented. Think about the brain like your car engine, okay? Everybody's got an engine up there that has different capacities at different times. And as nurses, one of the things I want you to think about is your own engine, your own brain. How do you think? What are some of the behaviors you have that you wish you could change? What are your relationships like? What is your past in terms of anything that might have interfered with your mental health and well-being? Have you had any abuse history? Look at yourself first and identify your mental health. Then you will have a better understanding when you're with others. Your own therapy is what makes you the best nurse. Okay? You can learn all the clinical stuff in the world, and if you don't understand human behavior, you can be a lousy nurse. Okay? Heather knows me well enough to know I'm very blunt. So forgive me if I say anything that you don't like, but these are 30 years of experiences that I'm coming out with. The other thing I want you to think about is your own gut, your own instincts. When you're at the bedside or when you're with somebody and you're listening with your whole self as a nurse, you pick up on nuances of people. And if you think about mental health as being equally important as physical discomfort, then you will pick up on those nuances. You will feel when you're in the presence of something, something's not right. I don't quite know what it is, but I'm going to ask myself some questions here. So I've got a list of a snapshot for a nurse. You don't have much time sometimes with people. You have very little time, as a matter of fact, and you're usually doing something. You're putting an IV together, you're arranging something, you're doing something when you're there. So picking up on those nuances, that snapshot is what I'm saying, can be difficult because you're always doing something. But here's some things to listen to. First, your gut feels uneasy. Does this person make self-statements that are negative? I always think of it this way. Do they know that they're loved and lovable? How do they feel? Ask yourself these questions as I'm going through this, by the way. What about their relationship? Who in the room is with them or not with them? Or is anyone with them? What do they describe in their relationships? Do they seem to you as being supportive, something that's helping them? Or you asking yourself about your own relationships? Behaviors. You know, we all get a little testy in quarantine. That's, of course. Behaviors that are consistent and patterned are our mental health. Okay? So we all get a little testy when we're in certain circumstances, but if we're always testy, or if we're most often anxious, or most often agitated, that's not healthy mental health. Okay? So behaviors is a really important piece. Thought process. If you're with someone who is mentally ill, you have a challenge communicating oftentimes. Something doesn't make sense in their pattern of thinking. And asking yourself, are there thoughts, are there behaviors, are there relationships, their self-esteem, are those feeling like they're in balance and healthy? So if you memorize those 5 things, that's a snapshot that'll take you all of like the whole time you're in a room to see. Become good observers, okay? I learned in graduate school, the most important time going into a patient's room was the 5 seconds before I walked through the door. That is your time to stop and center and breathe and ask yourself to empty of everything that happened the 5 seconds before, walk into the room and read the energy. Perfect example of this. There was a nurse who imposed whatever her mood was at the time on my dad when he was dying. She was a palliative care nurse, and she came bounding into the room where we were all quiet. We were all very still. We were grieving, and she comes in and she goes, "Oh, so how are you, Mr. Eastman?" And my father, in his very old-fashioned New England wisdom, said, "How the hell do you think I am? I'm dying." You know, so remember that 5 seconds. Because when you walk into a room, you read that energy, that helps you read what's going on with that person's mental health. It's not just the symptoms that are physical, it's the emotional symptoms. That nurse was absolutely clueless as to where my father's mental health was at that moment. He was sad, he was saying goodbye to his family, and it was incredibly insensitive of her to not read that energy. So you guys, you women, sorry, men and women, this is my New England coming out.
And it is recorded, so other men and
right.
women will be seeing this.
Men and women, exactly, it's a New England statement, sorry. When you go into a room, it's that 5 seconds of preparation that will help you pick up on these nuances. All right, so why is this important? Well, Heather has talked about it, and 1 in 4 adults, 1 in 5, 1 in 4, I've seen research both ways, suffer with a chronic condition like diabetes, asthma, and heart conditions. 1 in 4 or 5 of them have a mental health disorder. Okay, So the reality is when you are working with someone with a chronic health issue, chances are very high that they also have a mental health issue. The comorbidity of depression and pain is huge. I was just on the phone with someone and no one had ever said that. And that is really important for you to recognize that the mind and the body work together. So understanding that the World Psychiatry Journal published a statement that I thought this was fascinating. That people with mental illness die between 13 to 30 years younger than those who don't. Mental illness weighs on people. It weighs them down. It is very hard. You yourselves as healthcare providers, if you aren't dealing with your mental health issues, you will struggle so much more with your patients. They will trigger you and you will find yourself weighed down a lot. I used to work with death and dying, and I used to work with dying children. And if I hadn't learned to deal with my own mental health, my own grief around death and children, I could not have been present with those families. You as nurses have a responsibility to do that work, to understand your triggers, what makes you uncomfortable. And we know that mental health directly associates with outcomes of wellness in physical health. We know that. It's been proven over and over and over and over. How you think is how you behave, which is how you live. Okay? So remembering that that is really important. So what do we mean by mental illness? Heather gave you some slides. Well, I'm going to do a little more in depth of the nuances of what it is like when you're with a patient who is struggling with not situational depression, but major clinical depression. There's a difference. And the difference is continuity. The difference is you and I can wake up tomorrow morning and be in a bad mood and feel depressed. And we can go outside and feel better. Someone who struggles with depression, clinical depression, it's not that easy. And it comes back. So repetition, consistency of symptoms is a big red flag. So when you're with someone and they're describing, oh, I'm so tired of this. This is so hard. Finding out, well, does anything help? If it doesn't, then chances are pretty good it's heading in the direction of clinical depression. And your job is to pick up on that and refer to a mental health specialist. My number one conflict I have had consistently with nurses in 30 years of work is boundaries around mental health. It is because they think I understand emotions, I can understand mental health. Well, that would be like me saying to the two of you and all of you out there, oh, I can just treat diabetes because, well, I've read about it. So, I'm good at it. I can do that. I would never do that. That would be unethical and that would be just plain wrong. But I have seen nurses do this so many times because they're good people, they're kind people, and they think they know emotions. But mental illness is not about emotions. Mental illness is a medical condition. And just like I would never treat a medical condition, I'm asking you to never treat a mental health condition unless you have had training and you have been designated and certified. So please, 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 on behalf of all the patients I've ever struggled with this, don't do that. There are medical social workers, there are mental health providers, there are psychologists, there are psychiatrists, there are nursing specialists in psychiatry and psychology. Look to them first. If you have an inkling of any of these things I've talked about, go to them first and ask them, hey, I'm having this experience with this patient. I don't think it's right. Would you go in and assess? Okay. That's the most important thing I'm going to say today is if your gut tells you something and you look at these 5 questions, go to someone who knows what they're doing. Okay. So what do I mean by your gut? When you're in the presence of someone who's, say, bipolar, who is struggling with bipolar disorder, the way that I would describe how I feel usually is I go like this. Their energy draws me in because they're usually spinning. I call it spinning. There's a rapid energy. There's a sense of, I can do this and I can do that and I've done this, and they likely have it. If they're in a manic episode, they haven't slept. They've been doing a lot of different things that may strike you as, wow, that's really productive, but there's a different quality to it. So if you're feeling like this with someone, then ask yourself why. Okay? The depressive part of bipolar disorder is just as it sounds. Low energy, making negative self-comments, really a feeling of ugh, and not wanting to get out of bed. And what I want you to remember about bipolar is that it has all different flavors to it, or it shows up in different ways with different people, but it's the up and the down that makes it feel different when you're with someone who's bipolar. Now, those ups and those downs don't have to be so spread out, because the longer someone has bipolar, the more frequent they have episodes and the more intense the episodes are and the longer they last. So if you have that sense with someone, then right away ask the question, who can I go to who can assess? Okay? Eating disorders, you know, it's pretty obvious when you see someone who doesn't seem to be eating and you as a nurse is asking, well, are you nauseated? Or, you know, symptoms that you might ask them, but they're still not eating. And then maybe there's weight loss. Are they going to the bathroom frequently? You know, things to look for that kind of are clues that why are they not eating? So in all of these cases, you're always asking the question, why are they doing this? Why am I uncomfortable? We need to get to the answer. Major depression, we talked about. Obsessive compulsive, repetition. You know, right now, we're all a little obsessive compulsive because of sanitation. You know, I've never carried Purell around before, but we all are. So it's kind of hard to spot it that way. But what it is it's almost a perfectionism. It's a sense that I cannot do this. I cannot not open this door twice. I cannot not clean this. It's a sense of urgency. There's no way that I shouldn't do this. And so it's an absolutism about a behavior. Panic disorder is exactly when you are in the presence of someone who has a panic disorder, when they can't breathe and they're their feeling is helplessness. Your experience is exactly the same. You find yourself going, oh my God, they can't breathe. So breathing with them, getting into their rhythm, slow breathing, calming them, calming yourself in everything. And I know you learn this as in nurses training, stay calm. Mental illness, stay calm. Panic disorder, stay calm. Don't mirror your client, your person who you're with. It's easy to do. It's easy to get panicked. Again, get someone to help you who knows what they're doing, but most importantly, help them breathe. Personality disorders, headerline. I'm not one who loves labels, but the way you know someone is borderline is this. And I don't know if you can see it, but it's come closer, wham. Okay? Borderline personalities are fragile to different degrees, okay? But the bottom line is there's someone who wants to connect to people, but if someone gets too close, they push them away. So you might be with a patient who you think is the loveliest human being ever walked, and you get too close to them emotionally, you start to maybe talk about something that's a little too dear to them, makes them feel a little too vulnerable. Don't be surprised if they fire you. Okay? It's this, I call it the borderline bash. Come hither, bam. Okay, that's how it feels. It's whoosh. And so sometimes people will do that. You will get too close and they'll push you away. And sometimes borderline personality, they tend to do things to draw you in, like say they're going to complete suicide, be what people call negative attention seeking. That's their way of drawing you in. But then when you get there, they're uncomfortable, they're terrified. And that's the important part to remember, is they are terrified of your connection and they push you away. So if you get fired by someone and you're kind of going, what the heck just happened? Ask yourself that question. What's going on with their personality? Phobias, fears, unrealistic fears. I consistently ask people, is this something you need to be afraid of? Is this really something that could happen? To the best of your knowledge, is it real that you could have a, what's a good phobia? Germ phobia. Is it realistic that you could get sick from this germ? Well, we're living in a phobic age right now with COVID. So that's a really hard thing to tease out, but that's the question you ask. Is this a realistic fear? Is this based on reality? What is the likelihood that this person might fall off a cliff or whatever that they're afraid of, what their phobic fear? It becomes phobia when it's not realistic.
Katie,
okay?
can you speak to agoraphobia?
Agoraphobia? Sure.
Yeah,
agoraphobia, which some people right now are kind of sort of experiencing because they're afraid to go out of their safe space. And it is a thought process. Again, it's their engine not operating correctly because it's sending out messages that it's not safe outside. Now, in a pandemic, it's really not for a lot of people. But aside from a pandemic, an agoraphobic is terrified to step out of their door. So with every phobia, there's a thing we call, oh my gosh, I'm blanking. It's a gradual re-entry into
Desensitization.
Thank you. Desensitization. Thank you so much. It's desensitization. It's a gradual returning to whatever it is. So an agoraphobic, I've worked with an agoraphobic folks before, and it's a gradual learning to trust themselves. It's learning to feel safe in themselves, that they'll make good decisions and be able to protect themselves. So in a lot of cases, when people are afraid, they're afraid because they don't trust themselves. It's not the environment necessarily that they're the most afraid of, because there's always stuff we can be afraid of. It's not believing that they have the tools to take care of themselves. So trauma victims especially have a lack of a sense of safety because they don't believe that they can protect themselves. Okay? So speaking of trauma, PTSD. When you're with someone who's struggling with PTSD, nightmares, sleep disturbances, self-destructive thoughts, oftentimes, PTSD can go anything from an everyday thought disorder to someone I know who was a Vietnam vet who every night he would occasionally wake up in the middle of the night and throw his wife under the bed because he was believing he was being bombed. You know, we started learning about PTSD from war. A lot of the research was World War II. We understand trauma and the impact of trauma from research on kids and resilience. How did some kids make it through the bombings and be okay, and how did other kids not? And so we know that safety, sense of self-safety, is hugely important. And you as a nurse reassure people all the time. You'll be okay. You've got this. So I think that's a phrase that I want to really impress upon you. People need to hear that they themselves have got this, that they themselves can do this, that they themselves will take care of themselves, that they themselves will make themselves safe. Because if you rely on others, that's never something you can control, but you can control yourself. Make sense? Okay.
That's excellent.
We talked about schizophrenia. Schizophrenia is a very painful, difficult thing to work with and be with. I had a client who was very paranoid schizophrenic, and he would come into my office, and the way that we worked together is he would have to go through my office and make sure there were no bugs anywhere. And I mean bugs meaning listening devices, because he was paranoid. He was constantly being told by his voices that he was being listened to, that he had no privacy. So by empowering him to go through and make sure that he felt safe, he was able to talk to me about it. I worked in a mental health agency, or a mental health, what used to be called a mental health hospital in the olden days, when they were kind of like One Flew Over the Cuckoo's Nest. If you've never seen that movie, yeah, they were like that. I'm telling you, they very well were. And I actually have met patients and worked with patients who were very much like the ones in that movie, including the big guy who scared the bejesus out of me when I met him. The important part when you're working with someone who's schizophrenic is to join with them in being human. Okay? You can't take away their schizophrenia. That's not your job unless you're a psychiatric nurse and who understands meds, but you can be human. And so by my entering into his delusion and allowing him to have it rather than trying to tell him not to have it, it allowed him freedom to be human and connection with me. So when you're a nurse and you're struggling with somebody who just does not seem to be in touch with reality, and if you do any ED work, you are definitely going to come across someone who's schizophrenic. And I remember sitting with someone who said, gee, Katie, what do you think it would be like to be running around Saturn in a banana boat? And I said, gee, I don't know. What do you think? If I had said, oh, that's ridiculous, that doesn't make sense, I would have lost him right then and there. But instead I said, gee, tell me about that. Okay. So be human first with mental illness, always, and ask those really important questions. So speaking of questions so far?
It's not really a question, it's more of a statement. What you just said, it kind of reminds me, I work in geriatrics, so I have a lot of dementia, and some of them have auditory hallucinations or delusions. And one of the things I learned that works best is to go into their reality.
Yes.
Oh, you want to go pick up your kids? Okay, come with me, and then take them and can't let them leave the building, but like take them out, and then they settle down better instead of trying to deny them.
Exactly.
It's
yes.
Going into their reality because it's real to them.
Exactly. That's so true. My first supervisor said, don't take away their crazy unless you have something better to offer them. And a lot of times the reality of how people are living is so frightening that their delusions, their hallucinations, their alternative universe is much more comforting to them. When I worked in a state hospital, there was a woman who danced all the time. She just danced through life. She was in this really bizarre, constant delusion, but she was fine, you know, she danced. So what? That was her life. So don't try to remove exactly what you're saying, their delusion, unless you have something better to offer them. And in that case, you don't. Any other questions? Okay. Well, I want to talk about some more aspects of mental health that you as nurses can really help those of us who are in the mental health world with. One of those is advocacy. Okay. Part of your role as a nurse is to advocate for your whole patient, right? So becoming an advocate to make sure that mental health issues are not overlooked. Here's an example, and I was sharing this with Heather last night. One of my greatest learnings with working with nurses in a hospital was when a nurse came to me and a group of nurses came to me and said, you have to make sure this patient comes in for his treatments because he's consistently not showing up. And they were very angry. They were very judgmental. They were like, this patient needs to step up. And I asked the question because my brain as a medical social worker goes to those 5 things. And I said, does he have gas money? And they said, and I will never forget this, the nurse just went silent. And she said, maybe not. Nobody's ever asked him. So if you're ignoring social issues, mental health issues, which are connected oftentimes, then you're ignoring the why. So when you find yourself, which we all do, when patients trigger us, when you find that happening, asking yourself the question, why do you think that's going on? Go a little deeper. Is it physical? Is it emotional? Is it psychological? Is it spiritual? Is it social? Don't forget all of those. Okay, I'm going to repeat them again. Physical, emotional, psychological, spiritual, and social. If you can't, there was a wonderful article by the New England Journal of Medicine that said, you know, we can't even begin to ask people to deal with their mental health if they can't pay their bills. They have to have housing. They have to have food. They have to have comfort. Those things are most important, or we're not going to get them to deal with their mental health. Advocacy, we've talked about getting someone outside to do assessment. Your communication skills, learning how to communicate with I statements, learning to ask questions in ways that are inquisitive and caring. I'm sure you're doing that in your nursing classes. But remembering that communication skills, if you can't communicate, it doesn't matter how much you know, it won't work. Okay? And I always asked the question, what am I afraid of? If a patient or a client or anyone struggles with me, I ask myself immediately the question, what am I afraid of that I'm imposing on them? That's my communication issue. Be advocates for your community mental health. One of the things we did here in Anacortes was get people together to talk about mental health, to make it a community message and there are so many teenagers here right now in therapy that never would have been in therapy had we not addressed it with the adults. So be an advocate in your community. The things that I want you to put a note on is your own self-care, as I said. So here's one way you can learn your triggers. Your own self-care is called a loss inventory. Sit down at some point and write down every significant loss you've ever had in your life. How did you cope with it? What did you learn about loss? Do you know how to grieve? What is standing in the way of you being healthier? A loss inventory will really help you with that. Evaluation and research, stay on top of it. Mental health is changing all the time. Mental health research is changing all the time. Be an advocate by learning. Promote it. When you're having a conversation as a team with a group of colleagues, bring it up. Mental health, physical health, mental health, physical health, equally important, always. You start to become adept at saying, well, what about this? What about this emotion? What about this behavior? Why? Okay, why? It's easy to look at symptoms, but you gotta ask why. That's mental health. And I think more importantly than anything is what I said earlier, which is boundaries, your own professional boundaries. Know what you don't know.
Programs where, or at least I've heard of them, where people give, like, people with schizophrenia and mental health disorders housing before they've actually gotten better with their mental health, and as a way to try and promote them from get better. And I know there's a lot of controversies because a lot of people are like, oh, if you give someone who's on drugs a house, they're just going to lose it and stuff. But the important thing is if you give them something, then it's giving them something they've never had before, and it could make it so they get better because they want to not lose that. And I just wondered what your opinion is on it, because you work.
Well, back in the old days, in the 80s, we used to do that. Believe it or not, there was a program in New Hampshire that I worked with, for example, that was really wonderful. If you were diagnosed with a major mental illness, you were given an occupational job where it was called sheltered workshop at the time, where you would be doing kitchen work or something. You'd be given housing. You'd have regular mental health meetings with psychiatrists and social worker and a team approach. You would have group therapy, and it went on for several months. You would have this whole experience for the whole person for almost a year. And those were the days when we had money. That can't happen now. Now we're doing it in the community, but that's the exact same idea. It's if the person has a team of support around them, a psychiatric support person, a social support person, an emotional support person. If they have all those pieces, then there's no reason why they can't try independent living. But because that does empower people. However, it's different for every human being because some people have more risk than others. And a lot of people, unfortunately, don't have that kind of support. But there are programs around everywhere that give that team of support and do encourage people independent living. So it just depends on the case. But yeah, I'm a big proponent of that if there's a team. Absolutely.
I think that also speaks to, Katie, that sense of everybody needs a community and everyone needs to feel a sense of belonging for their mental health and a sense of connection. And the parallel to that, interestingly enough, that when we talk about rehabilitation of gangs, there's a priest by the name of Father Gregory Boyle down in Southern California, Southern LA, that has built as part of a team industry called Homeboy Industries. And recovered gang members are a part of this industry. They live in community with one another. They developed all sorts of industries to serve the community. And it's really spread like wildfire in a really positive way and drawn a lot of ex-gang members that are now helping rehabilitate other gang members. And while it's not mental health, it's a part of mental health, and it's a part of what you're talking about is that, you know, rehabilitation through team, through community, through connection, through a sense of increased self-esteem and a belonging.
Right. Exactly. It's a spiritual component. I need to be here. I have a reason to get up in the morning. When you want to try and understand what spirituality means, your spirituality is whatever gets you up in the morning. What gets you out of bed? What makes you keep going? That's your spirituality. Very different from religion. We create religion to adapt to our own spiritual beliefs. So we put religion on our meanings that we have, but our meanings are our spirituality, and everybody has them. You all have spiritual beliefs.